System disorders. We only got one chapter to cover tonight, and then after that, we are going to do some review for the exam, which is next week. There's no homework for this chapter 28, so that's so you have time to study for the exam, so there's no homework on that one. But we're going to start off, I'm going to skip the normal stuff, and we're going to start with the male anatomy, then do the female anatomy. So some congenital abnormalities of the penis. Epispadias. Epispadias is where the urethral opening is on the top or the ventral surface, as opposed to at the end. Hypospadias is the opposite. This is where the urethra comes out through the bottom. Hypospadias is much more common than epispadias, and even though you don't hear about these things very often, they're more common than you think. There are quite a few little boys born with these, particularly this one every year. And the treatment is surgical reconstruction. The urologists go in and they patch it up. They basically put the anatomy as close to normal as possible. You're smiling. Have you seen a hypospadias?
No, I was just thinking it would make the first few of the day interesting.
Yep.
I've met a couple, and I think more parents should know this is a possibility because I was like, oh, I'm a parent, I think I've heard it all, you know. And then I meet this couple while I'm trying to show them home, and they mention that their son has this, and you probably could have just read it on my face. I was like, this really happens. I think it was more like, what the hell would this look like? I think it's probably what I was thinking. But
yeah, this one's more common because it results from just as the penis develops, there's basically two parts that fuse together. And if the parts don't fuse, it's left open at the bottom, so the urethra comes out through the bottom. We don't have pictures to show on those, but they're interesting. In terms of disorders of the testes and the scrotum, here's another one you hear about quite a bit, is cryptorchidism. Crypto is strange or can't find, missing. So, and orchids, the orchids are can't think of the right word. The gonads, sorry. So cryptorchidism is can't find the gonads. So this results from the testes failing to descend into the scrotum. In the last few months before delivery, the testes form almost entirely over the course of the fetal life in the abdomen. And then it's in the last few months that they descend from inside the abdomen, very similar in position to where the ovaries are in the female. They descend down and out and into the scrotum. So if that descent doesn't complete, then the scrotum is basically empty because the testes haven't made their way down there yet. So we call it an ectopic testes. Any testes that's positioned outside of the scrotum, we call that ectopic testes. So cryptorchidism is one example of that. If this isn't corrected, it can cause the degeneration of the seminiferous tubules in the testes. That's going to cause infertility because spermatogenesis will be impaired because it's within those seminiferous tubules of the testes that sperm form. And then, in addition, this is a big risk. If cryptorchidism is fixed, testicular cancer is significantly increased. So anytime the testes isn't where it's supposed to be, isn't in the scrotum, you have a risk of both of these things, infertility and then cancer. So what normally happens is the testes forms up here in the abdomen, and then in the last few months of fetal development, it descends down, it goes retroperitoneal, and then it passes through what's called the inguinal canal, and then it makes its way into the testes. Now this canal kind of stays for a male's whole life. So this is one of the reasons why men are more likely to have hernias than women, is because this canal provides a canal between the intraperitoneal space, the abdominal space, and the scrotum. So one common form of hernia is that part of the peritoneum bows down in here and fills the scrotum. That's a congenital hernia, which you'll see oftentimes in kids. So other disorders, a hydrocele. This is another thing that occurs congenitally at birth. And it occurs when there is excessive fluid in the other space in the testes, and that's between the layers of the tunica vaginalis, which that detail isn't important, but basically it's a giant fluid cyst in the scrotum. And it can also be acquired as a result of injury, infection, or tumor later on in life. But the most common form is found congenitally. If it's left unchecked, untreated, it can compromise the blood supply by compression. It compresses the arteries and veins that supply the testes, and it gets in the way of lymph drainage, so it can damage the testes. Spermatocele is a similar kind of thing. It's another cyst in the scrotum that contains both fluid and sperm, so this is going to develop in men who are older post-puberty. But it can be related, again, to a developmental abnormality. So it may have been a defect present at birth that doesn't start to show itself until puberty when sperm production begins. So this, too, we have to surgically repair. And then a varicocele is a dilated vein in the spermatic cord. It's kind of like a varicose vein in the vein that drains the testes. So the spermatic cord provides the arterial and venous supply to the testes. So if you have a lack of valves there, we need those valves in the veins to get the blood back to the heart. If those valves are broken or absent, we get, when the male is standing, we have pressure in that venous, in that vein, and it causes that vein to dilate and causes increased pressure. That impairs blood flow, and that impaired blood flow results in decreased spermatogenesis again. So this too requires surgery. And then torsion is something you will see. Torsion in the testes kind of sit on this cord and hang in the scrotum. So they're free to move, they're free to rotate. And in certain kinds of traumatic injuries, the testes will basically twist on its own cord. And that causes dramatic compression of the arteries and veins. If you reduce the arterial supply, you're going to end up with ischemia and possibly infarction. So this has to be reduced as quickly as possible. And it can occur either spontaneously, as the scrotum moves and changes sizes, it may twist the testes, or more often following trauma. These are either treated manually, in other words, it's untorsed, it's untwisted. You can only do that if it's very recent. If it's been going on for any number of hours, you're going to have to do it surgically because the swelling will be such that there won't be room to move it. So some pictures. This is the hydrocele, so here's the scrotum, and we have this big fluid-filled sac here. This is commonly diagnosed in babies, infants in particular, and it'll present with an enlarged hemiscrotum. So half the scrotum is very big. And one of the things you'll see the doctors do is they'll get a pen light and they'll shine it into the scrotum. If it lights up like it's empty, that's a hydrocele. So that signals that you have to drain it. And then this would be the normal testes over here getting pushed up against the side. A varicosity, or the varicocele, this is where some of these veins that drain the testes are all enlarged and dilated. This is one of the hard to identify causes of male infertility. It's a varicocele. That's oftentimes where they get diagnosed, is in an infertility workup in a couple. So these have to be corrected to restore fertility, accurate and appropriate blood supply to the testes. And then a torsion. Instead of hanging nice and straight, these vessels have been twisted around, and that twisting causes compression, and when those vessels compress, it reduces the blood supply to the testes and can infarct the whole thing if left untreated. Torsions are particularly common in like 7 to 18-year-olds. Little boys are very commonplace on that.
What would be like a word used to describe it? Is it like painful on you?
Yes, it's painful. The presenting symptom is scrotal pain, usually out of the blue, because the trauma is not usually the typical trauma to the scrotum where you've fallen on a bike rail or something like that. It's something that causes a twist. So typically a kid will, out of the blue, have a red, swollen half a scrotum. And yes, it hurts a lot. The kids will be crying and demanding something be done. In terms of inflammations and infections, prostatitis is infection or inflammation of the prostate gland. There's 4 categories here. There's an acute and chronic bacterial, there's a non-bacterial, and then there's an asymptomatic inflammatory. So in acute bacterial prostatitis, the gland is very tender, very swollen, and then what comes through it, the prostate empties into the urethra. so that the urine contains both secretions and bacteria from the inflamed prostate gland. In the non-bacterial form, we don't see bacteria, but we see large numbers of leukocytes from the prostatic secretions and in the urine. And in the chronic bacterial, we don't have a lot of symptoms here. We have a slightly enlarged gland, and then we have symptoms of a UTI, so dysuria and frequency and urgency. We'll talk about some of the causes of prostatitis here in a minute. Oh, right now. The acute version is usually caused by E. coli, and sometimes these others. These are opportunistic bacteria from the gut. So these are gut flora bugs that have gotten their way into the prostate. Always problems with the cord. The chronic version is usually caused by repeated infection by E. coli. So prostatitis, we get this in young men with urinary tract infections, and usually in men, urinary tract infections are STDs. In older men, prostatic hypertrophy, which we're going to talk more about later, can cause prostatitis because it impairs the ability of the prostate to fully drain its secretions. And then anybody who needs to be instrumented, so like a paralyzed person who requires frequent catheterization, that catheterization has a high risk of infection that goes with it. So frequent infections is going to bring about that chronic bacterial prostatitis picture. And then another way is through bacteremia. If there's bacteria in the blood for whatever reason, say they've had abdominal surgery or say they've had major dental work, that bacteria can end up anywhere in the body. And the prostate is one of those places that it can grow and multiply and cause symptoms. So the signs and symptoms, dysuria, urinary frequency and urgency, so the classic UTI symptoms. So prostatitis can mimic the UTI. A decreased urinary stream. The prostate gland entirely surrounds the urethra in the male. So whenever the prostate gland is swollen, it has a tendency to impinge on the urethra and squeeze it closed. So that reduces the urinary stream and causes urinary frequency because the bladder can't fully empty against that increased pressure that's being placed on the urethra by the swollen prostate. In the acute form, you can get fever and chills because it's an active infection. So you're going to get systemic signs of active infection. Lower back pain. The ureters, bladder, and urethra can all refer to the lower back, in addition to the typical spots for the ureter. For the urethra. Leukocytosis, you'll see an increased white blood cell count. That's because we have an active infection going on. Abdominal discomfort, and then the usual systemic signs: fever, malaise, anorexia, muscle aches, common symptoms of systemic infection or infection anywhere in the body. We've talked about those before. Treatment is with antibiotics. Ciprofloxacin is a good one because it has good penetration into the prostate gland. And then for the non-bacterial infection, we use anti-inflammatory drugs like NSAIDs, as well as sometimes steroids. And then we'll do prophylactic antibacterial antibiotics because an inflamed prostate, even if there's no active infection, is more likely to get infected. So until we get that inflammation to go down, we want to keep that the antibiotics on board. So some of the tumors of the male reproductive system: BPH, benign prostatic hypertrophy. This is another you will see, and you will deal with patients who have this problem. It occurs in up to 50% of men over age 65. This is one of those that people say that the longer you live, the more you're likely to eventually have this, that it's kind of an inevitable progression. The older a man gets, the more likely they're going to have BPH, so that by the time they get very, very old, everyone who's very, very old has this, who's a male. It's basically hyperplasia of the prostatic tissue. So the prostate gland isn't really sick, it's just getting too big. The cells are dividing, there gets to be more and more cells, and their cells get to be bigger, so it gets bigger and bigger. And because of its location surrounding the urethra, that's what causes the problem. So with BPH, the big concern is not that it's big, because it's not cancerous. It doesn't predispose to cancer. It's that the bigness of it compresses the urethra and then causes urinary obstruction because the urethra gets smaller and smaller and smaller until urine can barely pass through it. It's related to an estrogen-testosterone imbalance. So as men get older and their hormonal balances change, because people used to think that men hit puberty and stayed the same way the rest of their lives, but that's not true. There's an ebb, reduction in testosterone as men get older, so the estrogen-testosterone ratio changes, and that's one of the causes of this BPH. So here's an example. Here is the prostate gland. This whole thing is the prostate gland. The urethra goes through the middle. This should be about this size. So this is very, very big. And you can see here's the bladder. So this prostate gland is almost as big as the empty bladder. So if you remember your anatomy pictures, that's way, way too big. It's diagnosed on digital rectal exam, and this unfortunately doesn't have anything to do with digital as in devices. This is using the finger rectal exam. And it's, so an enlarged gland is palpated in that way. It causes frequent infections because of urinary stasis. So because the bladder can't empty, there's always a little urine in the bladder. That's a setup for infection no matter what the cause is. So we have frequent urinary tract infections because of BPH. And then if it continues to stay obstructed, distended bladder, dilated ureters, basically that pressure that can't get through the urethra backs up. So the bladder swells, and then when the bladder can't swell anymore, the ureters swell, and that increased fluid goes all the way up to the kidneys and eventually will cause hydronephrosis. With hydronephrosis, those renal pelvises where the urine first enters the ureters, they get swollen, and as they swell, they push the kidney against its own capsule. We saw a picture in the urinary system of hydronephrosis and how it can basically just squeeze the kidney out of existence. So that will cause renal failure if this isn't treated. So the progression here is BPH causes the urethra to be compressed. That obstructs the flow of urine, and we get the cardinal symptoms here, which is difficulty initiating the voiding stream, so starting micturition, hesitancy, that's called, and then dribbling. In other words, the urinary stream has gotten so small that it's just a dribble. That causes an incomplete emptying of the bladder, so you get frequency. The bladder fills just a little and finally has enough pressure to push through, but it can't empty completely, so you have this little tiny urinary volume that's being stored and emptied. So you get frequency, infection, and then the bladder distension, hydronephrosis, and kidney damage. So this is a thing we have to fix to prevent these progressions. So these we've already talked about. In addition, nocturia, if your bladder is full when you go to bed, you're not going to be able to sleep through the night. So you're going to end up having to get up to pee a lot at night, which is nocturia. And then dysuria if there's infections. So treatment, we have some medications that treat this. This one you may have heard about on TV, Avodart. It slows the enlargement of the prostate, so it slows the progression of the disease. And then medicines like Flomax relax the smooth muscle that's in the prostate gland and can help to restore urinary flow. And that's what we need to do. We need to reduce that urethral constriction and return urine flow to normal so that we can empty the bladder and avoid those other complications. And then the combination of Proscar and Cardura, Cardura is actually a high blood pressure medicine, but it works here too, also reduces the progression of the hypertrophy. If necessary, surgery can be done. And the whole prostate doesn't have to be removed. That's usually reserved for cancer. Instead, they'll remove enough to relieve that urethral compression. But cancer of the prostate is a concern. So just an enlarged prostate isn't necessarily a bad thing, as long as it's not impeding the urethra. But cancer is. So it's the most common form of cancer in men over age 50. So as our population continues to age, as there gets to be more and more people over age 50, we're likely going to see more and more prostate cancer around. So it's the third leading cause of death in men of all ages. 1 in 6 men are affected. all these are saying this is a common disease. So most of these cancers are adenocarcinomas that arise near the surface of the gland. So that's just the specific kind of cancer that it is. It's a glandular cancer. The more undifferentiated the tumor, it follows the normal rule that the more undifferentiated the tumor, in other words, when you look at the cells under the microscope, if you can't tell what the heck kind of cells they're supposed to be, that's concerning. That means that that tumor is going to be more aggressive. And many of the tumors are androgen dependent, so it means that they require the presence of androgen to continue to divide. This provides a treatment option because if we can squash the androgens in the patient, we can reduce the spread and development of this tumor. So it'll explain some of the therapies we'll talk about in a minute. Prostate cancer is both invasive and metastatic. Some are highly aggressive, some aren't. 5 to 10% people think are caused by an inherited mutation. So it's not that you developed the cancer, you inherited it, but it takes a long time to develop. And then other causes, high androgen levels, like high testosterone levels. This is one of the reasons why testosterone shouldn't be given to men that don't need additional testosterone, because it can increase the risk of cancer in the prostate. Insulin-like growth factor, and then a history of recurrent prostatitis. So the prostatitis that we just talked about, because of chronic inflammation, chronic turnover of cells, that always increases the incidence of cancer. So anytime you have a tissue that is inflamed on a long-term basis, you're going to see an increased incidence of cancer because those cells are turning over faster, they're more metabolically active, and they're being stressed all the time. So one of those responses is to become cancer. So here on exam is you feel a hard nodule on the periphery of the gland, so not in the middle. It's not like BPH where the whole thing is just big. Here you have a hard, firm nodule in just one spot of the prostate. But we get some of the same symptoms as BPH. So hesitancy, decreased urine stream, frequency, and then recurrent UTIs. So when you see these symptoms in a patient, the most common thing is BPH, benign prostatic hypertrophy, like we talked about. But because it's the very same symptoms of cancer in that prostate gland, we have to make sure we have to rule out cancer before we start BPH therapies. So one of the ways that we do that is with blood markers, PSA or prostate-specific antigen. In some cancers, this is secreted by the cancer cells themselves. So if PSA is present, it's highly suggestive of cancer. The problem is if PSA is absent, it doesn't rule out cancer because not all prostate cancers secrete PSA. And then prostatic acid phosphatase. This is an enzyme found in the cells of the prostate. Tumors are never healthy, so the cells are always breaking down and dying and infarcting and things like that. So when we see this in the blood, it means that there's something wrong with the prostate, and that something wrong with the prostate may be cancer. So ultrasonography, we look at this with the ultrasound machine, because in BPH, we're going to see a uniform enlargement of the prostate gland. In cancer, you're going to see one area that's enlarged with an otherwise normal gland. So we can tell a little bit from how it looks, which thing it's likely to be. But biopsy is really the gold standard here. Like so many tumors, you have to take a piece of it to make sure that it's cancer and not something else. And then because this metastasizes and often has done so by the time diagnosis is made, we do bone scans to look for metastases in the bones and the rest of the body. Treatment is surgery. Here we are going to remove the whole prostate gland. So this is radical prostatectomy. That means you take the prostate, some area around the prostate, and very likely some lymph nodes in that area too. And then radiation is done to prevent metastases and recurrence. So this can be either external radiation or implanted pellets. This is where they take some radioactive material and they put it in the region where the surgery was just done to help to kill any remaining cancer cells that are present. If the cancer is androgen sensitive, then orchiectomy is effective. This is removing the testes. You can imagine there would be a lot of resistance in men to using that as a treatment option. So there are lots of anti-testosterone drugs that are present that we have to work with today that block the secretion of testosterone until the cancer can be dealt with. And then, as with most cancers, there's always new chemotherapies in the works. So that's the prostate gland. Cancer of the testes. Most of these are malignant, and it's 1 in 300, so 1 in 300 men is affected by testicular cancer. It's the most common solid tumor in young men. Usually in that age between 12 and 35, there's very few things that go wrong with men or women. But this is one of the things that comes up in that golden age time frame, in the time of peak health, is cancer of the testes. So it can affect people in a huge way because they're otherwise healthy. They're just starting out their lives. They're vigorous, athletic folks, and they have cancer of the testes. The number of cases is increasing, and just like one of the ways we combat breast cancer is with self-examination. Today, men are being encouraged to do testicular self-examination so that we can, because if the cancer is detected early, it has very good treatment outcome, very good prognosis. But oftentimes, they're not detected until way into the course when they start having other symptoms in other parts of the body, so metastases. So we want to detect it early so that the prognosis is better. And here's a picture. Here's that spermatic cord. Here's the normal testis over here, and then attached to it is this giant tumor, which you can see is almost the same size as the testis itself. So these can get very big. It can come from any of a number of cell types, either one or mixed. And just like we'll see in ovarian cancer, the testes can form teratomas. And teratomas are really bizarre tumors because most tumors come from only one root type of cell, either a epithelial cell or a connective tissue cell or an endocrine cell. Teratomas can result in any of the cell types. So you can get very bizarre things in teratomas, things like hair that grows inside the tumor, teeth that have grown inside the tumor, ears. People have seen ears inside of tumors. Because basically this is a tumor of the germ cells. So these cells know how to make an entire human being. So they have all kinds of abilities to make bizarre things. So if you hear about a tumor like on a board exam that has some bizarre characteristic like that, that it's got teeth or hair or skin in it or something like that, it's a teratoma. Anybody heard of teratomas before?
I had a cyst like that removed.
Yeah, that had something weird in it?
Hair.
Yeah, that's teratomas. Because it's the same stuff that would make a baby, it's just there's no organization to it, so it's just making stuff.
Oh,
yeah, it's bad. And then some of these testicular tumors will secrete HCG, that's the pregnancy of hormone, usually the placenta makes HCG, or AFP, which is alpha-fetoprotein, one of the things we check for on that triple screen. So we can use the presence of these as markers for testicular cancer. And more importantly, it gives us a tool to follow progress. So if a patient's HCG is very high, we do surgery, we do radiation, we can follow that HCG level to make sure that a recurrence isn't happening. So the typical spreading pattern is that it appears the cancer metastasized to the iliac and para-aortic lymph nodes. So these are regional. These are up closer into the abdomen. And then it'll spread to the mediastinum and the supraclavicular lymph nodes, so it spreads in towards the chest. Then it breaks through into the blood and can travel anywhere. So lungs, liver, bone, brain, all the places that cancer usually travels once it gets into the blood. So the causes here, one version is hereditary and results from a change in chromosome number 12, so something you get from parents. Cryptorchidism, which we started the night talking about, is one of the predisposing factors. So if you don't get that testis out of the abdomen or remove it, it's likely to develop cancer of the testes. And then some environmental agents, herbicides can predispose to this condition. So you see an increased incidence of this in farm workers, people who harvest or spray because the herbicides are cause an increased risk. So the signs and symptoms, usually the tumors are hard but painless, so they don't hurt, but they're very hard, and it's usually just one side or the other. It would be very rare to have one on both sides. The testes can be enlarged or feel heavy depending on where the tumor is in the testes, and you get a dull aching pain in the scrotum and the pelvis. Hydrocele or epididymitis might develop, and this is as a result of obstruction of the fluid flow, which in the case of a hydrocele, or of the semen flow in the case of the epididymitis. And then gynecomastia, this is the development of breasts in a male. So you see the budding of breast tissue and things like that. And that's if the tumor secretes hormones, because these teratomas, like I say, can do all kinds of things. And one of those is to secrete estrogen or progesterone or prolactin or HCG, all of which can cause that. The diagnostic tests, biopsy is usually not done. This is to prevent try to reduce the risk of metastases. You can imagine putting a needle into this thing is going to breach the barrier between blood vessel and tumor. And because this tumor is so vigorously metastatic, we want to prevent that. So we usually don't do a biopsy because typically you're going to remove it anyway. Tumor markers, like I said, HCG and AFP to see if they're present. If they are, that's very suggestive of cancer. Ultrasound, CT, and then looking at the lymph vessels and blood vessels by X-ray. Treatment, surgery, you're going to remove the whole testis. You're not going to just remove the tumor, you're going to remove one whole testis and the tumor attached to it. Then you're going to do radiation therapy and chemotherapy. One of the suggestions is that the clients store sperm for future use to ensure future fertility, because while they're likely still going to have one testis, this radiation therapy and chemotherapy to that region may very well make them infertile otherwise. So they want to do a stockpile sperm, so to speak. Yeah.
Would they recommend testing on their chromosomes to make sure it's not hereditary before?
They wouldn't do that because the hereditary version is rare enough that they wouldn't do that. And it would be exceedingly hard to do that anyway, to actually test sperm for those things.
No,
So that's the male in a nutshell.
I meant would they test the person before after if they want to know?
Oh, yes, they would do
To see
that.
if they have
Yes, they would find out
Okay.
if the patient had the
Okay.
chromosome. Yeah. All right, so on to the female side of things. So we'll start, just like we do with the male, with the structural abnormalities. So the uterus, the normal position is that it's slightly anteverted. That means front facing, and anteflex. It's not straight. It has a bend to it. And then the cervix is downward and posterior, but there is variation to this normal position of the uterus, some of which causes problems, some of which doesn't. So retroflexion is where it's tipped posteriorly, and it can be curved or bent because it doesn't have any place else to go. It can't be in its normal shape, so it's going to bend to match the curve of the sacrum. And it can cause back pain, dysmenorrhea, or dyspareunia. This is pain with sexual intercourse, in case you didn't know what that word meant. And sometimes it can cause infertility, because if the uterus is not in its normal anatomic position, then it's difficult for implantation to occur, and sometimes it's difficult for the egg that's released from the ovary to make its way into the uterus in the first place. So these abnormal positions of the uterus can be a cause of infertility. So here is some of those abnormal positions. So the normal, let's see, is normal not listed here? Normal, see this dotted line here? So the uterus slopes or bends anteriorly, and then it has a kind of slight anterior curve. So anteflexion means it's curved too much. It's bent over, and you can see that it's kind of impinging on the top of the bladder there. So that might cause a reduced bladder capacity. Retrocession means that it's too far into the pelvis. So, and you can see that the vagina and the cervix don't quite line up, which could cause problems with infertility there again. Retroflexion, instead of leaning towards the front, it leans towards the back. That's what we just talked about. And then retroversion, there's multiple different degrees, but this is where it's basically lying against the back of the cervix. This is bent towards it. This is lined against it. Some other structural abnormalities. These are ones that typically occur over time. And uterine displacement, or otherwise called uterine prolapse. This is where the uterus is basically dropping down into the vagina. These are usually caused by multiparida, so women who've had many children. The more children you have, the floppier your uterus gets, and the floppier your pelvic musculature and ligaments get, because 4 or 5 times now they've been stretched all out of whack, and there's only so much elasticity and return to normal you can expect. So
when I won't keep having keys, can I say keys?
well, in the old days, people used to do that very commonly.
I know, but I'm just saying, you were saying fell out too?
That is one of the things that happens with having too many kids, is quite literally your uterus falls out.
17, 18,
I know.
She had 19 prolapse. I think she had 1 uterine prolapse and 2 bladder prolapses or something.
Yeah, and it's because the musculature down there just falls apart, and things. Yeah,
Yeah, you can't even cough anymore.
that's true. Not until you get it fixed anyway. So we divide these into different degrees. In the first degree, it's only the cervix, which is the narrowest part of the uterus, that drops into the vagina. In the second degree, the cervix lies at the opening of the vagina. So the body of the uterus is in the vagina, and the cervix is right at the end. And then in third degree, the uterus and cervix are quite literally falling out. So it's prolapsed outside of the body cavity. So believe it or not, prolapse can be asymptomatic in the early stage. The women don't notice. And then in the
They don't know
advanced,
about
well, they would notice it by the time they get to here. But in first degree and second degree, they may not notice because it doesn't hurt. And if they're not sexually active, they would not notice. Because people don't check these things.
Now, truly, is that something like, especially like in the early stages, that your male partner would be more apt to notice maybe than you even?
Yes.
Okay.
Yeah.
It's funny.
Yeah. Something is
Something is
not right.
not right.
Would be what Stephanie would say.
Like, whoa, what the heck?
Right. Something is not right. I'm sure that's one of the reasons these women, particularly first degree, might come in, because otherwise they wouldn't notice.
Right.
Let's see. And then in the advanced stages, you're going to have blood flow changes. Now the uterus is not in its normal position. So you're going to have mild ischemia, you're going to have mild infarction, so that's going to start causing discomfort. If the tissue breaks down, it's not in its normal position, doesn't have its normal protection. The cervix is not meant to be exposed to the outside world. So the tissue is going to break down, cause infection, and then obviously decreased mobility. So here's what that looks like. So normally the uterus is up high, the cervix protrudes down into the vagina. As prolapse occurs, it basically telescopes inside out. And this would be a third degree, where there's actually, you can see the cervix on the outside. Always a good disturbing topic.
How do you fix that?
How do they fix it?
Shove it back in?
They do. The good gynecologist will pull it back in, and they'll tack it to something.
I was like, do they do like
They'll
a
staple it to the wall.
They stitch it with stitches that don't fall apart like nylon stitches, and they'll stitch it to the posterior abdominal wall or to the sacral ligament, something that's going to hold it up in position.
with like a hysterectomy?
Yes, if the woman is past childbearing age, yes.
Okay.
And I would imagine they're not going to stitch this back up; they're just going to remove it.
Pull it out.
But they're also going to tighten up the pelvic musculature.
Hysterectomy would be
So that things don't happen. Because here we got some other things coming that are related to the same thing. So like I said, the more that perineum, which is the bottom floor of the pelvis, the soft tissues in the female perineum, the more they're stretched with childbirth, these other things can happen too. So a rectocele is where part of the rectum protrudes into the posterior vagina. Because there again, there's that, it's just soft tissue that's there. So as that soft tissue gets weaker and weaker, protrusion can happen, and the pictures make this much more clear. And a cystocele is where the bladder protrudes into the anterior vagina. So if these conditions are severe enough to cause symptoms or other problems, then surgery is done to basically tighten up those pelvic ligaments so stuff will stop moving around the way it
So
should.
doesn't this also cause, what do they call it, a fistula? Is that what they call
It
it?
can cause a fistula, yes, where you'll have fecal matter coming out of the vagina. That's what you're talking about.
So how did the rectum start to bulge?
I know. we-
Well, okay, so normally the vagina would be here and it would have a nice firm wall. But after many stretchings from delivery, this wall gets weaker and weaker. So when you go to Valsalva to defecate, some of that pressure is going to push this way instead of out. So
what if it's just from lumbar?
it would be the same thing, weakening of that vaginal wall together with, this area of the rectum gets a lot of pressure put on it to evict feces. So if feces is hard, constipation happens, this is going to bulge into the vagina because it's the next weakest spot, other than this way. And then the cystocele is kind of the other way. So the bladder has prolapsed down into the vagina. All right, so those are the structural disorders.
That was special, that was fun.
Should ask much more,
Better than
many
that.
more questions came about this topic than.
Better,
Always. The reproductive system is always full of topics, or people are always full of questions.
that was better than the crabs that we were talking about last time.
So menstrual disorders, again, very common disorder set of disorders of the female reproductive system. A lot of women seek medical care for menstrual disorders of various kinds, so it's good to know the basics about them. So in terms of the abnormalities, amenorrhea is just the absence of menstruation. It can either be primary or secondary. In other words, you never started menstruating, or you menstruated normally and then stopped. So in the primary case, it can be genetic. This can be the first sign that there's something wrong with the chromosomes, like Turner syndrome. It can be the first sign that there's a congenital malformation, like absence of the ovaries, or a cervix that has no opening is one of the primary common cause for primary amenorrhea. So the menstrual cycle has been proceeding for several years, but there's no place for the tissue to go because the cervix has no opening. A complete hymen is another cause of this, where if the hymen has no hole in it, the same thing will happen. You won't see any menstruation. And then the secondary amenorrhea is usually hormonal imbalance, but it can also be caused by things like malnutrition. We see secondary amenorrhea in anorexics. We also see it in people who are undergoing vigorous athletic training. Because as the body is stressed, one of the things that will happen is the menstrual cycle shuts down to try to conserve resources. Dysmenorrhea is painful menstruation, and it's caused by prostaglandin release. Every month, the endometrial tissue, the reason it sloughs off is it loses its blood supply. So that's ischemia. Normally, that's painless, but in some women, that triggers prostaglandin release, kind of a little mild inflammation or even severe inflammation. And those prostaglandins cause cramping, they cause pain, they cause tenderness. So usually in dysmenorrhea, it begins a few days prior to the menses, and that's because that's the time when that blood supply is shrinking back and the ischemia is starting, and then can last a few days after onset. NSAIDs are a friend here. Naproxen is probably the most commonly prescribed of the NSAIDs for this because it's long-acting and quite effective. Yeah.
Why does birth control make your cramps less?
It results in less buildup of endometrial tissue in the first place. So it usually makes menstrual flow less. And if the less tissue there is, the less tissue there is to be ischemic, so the less pain there is. Yeah.
Is there any harmful effects of not having a period? It's like a lot of.
No.
No, okay.
There's not. People have really studied that. And I know that question comes up a lot because it really bothers some women that, well, what do you mean there just won't be menstrual flow? But
I think with like, I have my implant after my twins because I'm scared. And I noticed like, you think like everyone's like that, your body needs to get rid of it. You notice you have like those cycle differences then. Or like one's better or worse than the other, you know? And so I think that's your body's way of saying, okay, you know, just load, okay, we'll wait, you know? I
Right.
think your body is self-adjusting in that sense, and women don't see that sometimes, that, you know, it will do what it needs to do.
Yes, and it will, and right over the top of whatever hormones we throw at it
Oh,
too.
yeah.
You know, it will readjust to whatever hormones we put in. It's the hormones that we give as medicines are not the end point. The body's gonna respond to those things too. What are you saying?
So the new birth control pills they have out there where you're only gonna have your period every 3 months or whatever.
That's fine.
There's no harmful effects
No.
of that at all?
People would keep looking because of just the comment that you made. It bothers some people. So
Oh, it wouldn't bother
they
me at all,
keep
I just don't,
looking.
my daughter
Because they
just
say
says, why should we have one?
it's unnatural to not have one. And what medicine has found is it doesn't appear to cause any problems. There may even be a benefit in it. Because the less endometrial cycling you have, you know, the less likely you're going to have endometrial cancer, the less likely you're going to have some of these other things. So those kinds of birth control methods are here to stay.
So it's okay to just be on birth control for a long time, like several years?
All the evidence points to that. Yeah. Now what they have found is you can't stop and be fertile the next month. It may take 6 months or even a year to restore your fertility.
You
Which
can, but you might
Yeah,
not.
Right. You can't.
Let me tell you.
Right. You can miss one pill and be fertile that day. But I think one of the reasons we see a lot of infertility workups in young women today is because they've been on birth control and it takes a year, you know, to really get back into a cycle of fertility again. So, all right, other menstrual disorders, premenstrual syndrome. This starts about a week before the onset of menses. We don't know exactly what causes it, and it can be many different forms. Common symptoms: breast tenderness, weight gain, like water retention, abdominal distension, bloating, irritability. Look at all that big long list. You guys know
We're
about
all
this
very
one.
familiar.
Yeah.
Yeah.
Right, I don't need to teach you about this one. Right? So treatment is individualized. You got to figure out what works for you. Exercise is a good one. Salt intake limitation, that helps to prevent the abdominal distension, but you kind of have to stay on top of it. You have to know when to restrict your salt intake. Oral contraceptives have a tendency to balance out the hormonal big shifts that nature makes, so that can help with premenstrual syndrome. And then diuretics and antidepressant drugs like the SSRIs. Chocolate, Midol, caffeine, all these things are frequently used.
And Chick-fil-A's, then you're good to go.
Chick-fil-A. I hadn't heard that one before.
I watch Family Guy.
All right. Another very common thing women will come in seeking medical help for is abnormal menstrual bleeding. So there's lots of potential causes for this, but this is an important thing to highlight. The usual cause is lack of ovulation for whatever reason. So if bleeding is out of time with the cycle or it's gone on for a long time, the most common cause is for whatever reason ovulation didn't occur. So there's been a slow and steady buildup of endometrial tissue. And there's only so long that can go on before the endometrial tissue starts to break down. And then you get a constant blood flow or a non-normal pattern to it. But it can also be a hormonal imbalance between the pituitary and the ovary. And we'll talk about an example of that here in a little bit. So the words here, in case you didn't know them already, menorrhagia is an increased amount and duration of flow. So this is too much flow. Metrorrhagia, these are hard words to say. This is bleeding in between cycles. Polymenorrhea is short cycles, so cycles less than 3 weeks. And then oligomenorrhea is not enough cycles. Oligo is just not enough. So this is long cycles, so every 6 weeks or more. Endometriosis, very common disease of the female reproductive tract. And basically endometriosis is simply endometrial tissue is present in places other than the uterus. And the endometrial tissue that's elsewhere still responds to the hormones of the uterine cycle. So even though it's not where it's supposed to be, it's behaving normally, but because it's behaving normally in a place that it can't shed the resulting tissue from, it causes the symptoms that we're going to talk about. So the bleeding in these inappropriate places, these ectopic places, causes inflammation, because very commonly you'll end up with thin blood in the peritoneal cavity, which is the most common place we see ectopic endometrial tissue. That bleeding causes inflammation, an inflammatory response, and then lots of pain in various areas, depending on where the ectopic tissue is. Over time, this inflammation will cause fibrosis. So wherever that ectopic tissue was, it begins to scar. And as it scars, scars don't pay much attention to the normal anatomy. They just try to seal whatever the hole is or seal whatever the problem is. So you can end up with intestines stuck to the inside of the abdominal wall. You can end up with intestines stuck to liver or intestines stuck to ovary. And those are what we call adhesions, fibrous tissue that develops because of this ectopic endometrium trying to slough off every 28 days. The cause hasn't been established. Even though this is a common disorder, we don't know what causes it. But congenital is to be considered, at least in some cases where it runs in families anyway. The treatment here, hormonal suppression. This is birth control pills usually, or other kind of hormone modulation, but usually it takes the form of one of the versions of birth control. And then if it's severe, you can go in and remove that ectopic tissue. They don't do that. They try to avoid doing that because it's just going to end up somewhere else. Opening up the abdomen is another cause of adhesions, and now you've disrupted the normal anatomy, and you may have made this problem worse. So they try to treat it with other treatments besides surgery. Even though surgery seems to make the most sense, it actually tends to make it worse. So this is just showing you that this endometrial tissue, which is the green stuff, can be anywhere. And in part, you know that the uterus is open. It's connected to the fallopian tubes, and the edge of the fallopian tubes is not closed to the peritoneal cavity. So it isn't hard to think that endometrial tissue can kind of work its way up to the edges of the tubes and then out, and now it's in the abdomen, and it's going to divide, and it's going to get all over the place. So these can really be anywhere, including externally, like in the perineum. So you can have a little spot of tissue that bleeds. What these look like is just little spots of red, very richly vascular mucosal tissue when you look at it under the grossly anyway. So in terms of infections, candidiasis, this is your classic yeast infection. It's not sexually transmitted. This is most of the other infections we're going to talk about are. But it's caused by Candida again, same cause of thrush, or same fungus that causes thrush. Candida. Opportunistic infection. This is normal flora. Candida is found in the vagina anyway. And Candida is ubiquitous around humans. So we have it on our skin, we have it in our hair, we have it in our mouths. So this is going to be an opportunistic infection. In other words, it's going to take hold and kind of bloom when there's something that eliminates its competition. So antibiotic therapy is a classic one. You're on antibiotics and you develop a yeast infection. It's because the bacteria have been taken out of the competition and the yeast take over. So then you have to be treated for that too. Pregnancy causes changes in the pH of the vaginal secretions, so that too can tip the balance towards a yeast infection. Diabetes causes the glucose level in the secretions to go way up, and it's a yeast. It likes sugar, so it's another cause for a bloom. And then reduced host resistance. All of these normal flora are held in balance by our own immune system. So when our immune system gets decreased for whatever reason, whether it's you're fighting off some other infection or you're on immune suppressing drugs, that can cause a bloom of Candida too. The symptoms here, red and swollen mucosa, very pruritic, itchy in other words, and then a thick white curd-like discharge. So it's typically not subtle. It can extend to any of the other vulvar tissues, and the treatment is antifungal. There's oral therapies and there's topical therapies. Lots of good options for treatment. Pelvic inflammatory disease is an infection that is a major cause of infertility in some parts of the world. This is just any infection of the internal uterine or the internal female reproductive system. So the uterus, fallopian tubes, ovaries, any infection there we'd call pelvic inflammatory disease. So it can be either acute or chronic. Usually it's an ascending infection. So an infection in the lower reproductive tract, like the vagina, moves steadily upwards and infects more and more of the reproductive system. But it can also be due to bacteremia, just like prostatitis. You know, prostatitis is usually from an ascending infection, particularly an STD. Pelvic inflammatory disease, same thing. It's usually an ascending infection. But it can be from bacteremia. So I think we point this out because sometimes we don't trust patients' answers when they say, you know, are you sexually active? And they say no. And we assume that if they have pelvic inflammatory disease that it must be an STD that they don't want to tell people about. But the reality is you can get it in other ways, and that's from a bacteremia. So sometimes we have to just believe our patients a little and then not believe them to be sure. But like I say, the majority of infections arise from STDs. Non-sterile abortions in other parts of the world are a common cause of PID because you're basically introducing bacteria into these areas. And then postpartum. During the delivery process, often, particularly here in America, there's lots of instrumentation. You know, we put monitors on the baby's head. We put monitors up inside the uterus. So we may have introduced infection. Or infection can be introduced during the birth process anyway. So pelvic inflammatory disease is really seen on this side. You know, this is the normal anatomy. And this is just showing you that an infection in the vagina, a vaginitis, goes up into be a cervicitis and then works its way up through the tract until eventually it's taking the whole thing and infecting the whole thing. So these are just the different names. Endometritis is infection of the endometrial lining. Salpingitis is infection of the tube. Peritonitis can result as that infection comes out and spreads around the peritoneal cavity, which is all around here. And then oophouritis is actually an infection of the ovary itself. Oophouritis. It's a primary cause of infertility because of the scarring that results. You know, the fallopian tube is not very durable in terms of infection. So when it gets a bad infection and it starts to scar, that tube can get blocked or become dysfunctional. So you'll have infertility. Also, ectopic pregnancy. As that tube becomes abnormal in shape and function, instead of wafting that fertilized egg towards the uterus, it may not be able to waft anymore with those little cilia in there. And then the fertilized egg will implant in the tube. And then other complications, peritonitis, that's infection of the abdominal cavity. Pelvic abscesses, there's lots of places in the pelvic region where a bacterial infection can hide and grow and form an abscess. And then septic shock, as the systemic effects of this widespread bacterial infection take hold, we can get those things like low blood pressure and high heart rate and things like that. So pelvic pain is usually the first sign. Pelvic pain looks a lot like abdominal pain, only it's lower. So we have a temperature, guarding of the abdomen, nausea and vomiting, high white count, purulent discharge may be present. Experienced OB-GYNs will tell you about the pelvic waddle or the pelvic gait, the pelvic walk, and it's because they hunch over and they don't want to move and they kind of shuffle along. That's PID until proven otherwise. We usually treat these patients in the hospital with aggressive antibiotic therapy, and that's to try to reduce the complications as well as the potential outcome of infertility. So we don't see a lot of PID here, but in other countries it's rampant. Wherever STDs are rampant, PID is going to be rampant. So some benign tumors of the female reproductive tract. Fibroids, many of you have probably heard of these, also called leiomyoma. These are tumors of the myometrium. So the myometrium is the muscular part of the uterus. The endometrium is the inner lining that changes with the uterine cycle. The myometrium is the smooth muscle part. And fibroids are tumors of that smooth muscle tissue. They're very common during the reproductive years. They're classified by their location. And usually when they're diagnosed, there's several well-defined but unencapsulated masses. So they don't form a capsule, they're just overgrowths of smooth muscle tissue in the wall of the uterus, in the muscular wall. They can cause abnormal menstrual bleeding, and that's because they deform the shape of the uterus, so they can make little nooks and crannies, and they can make an abnormal shape that endometrium can't adhere to as well. And then they can interfere with implantation. So this would be a form of infertility. If you have lots of fibroids and they're in bad places, that disrupted or distorted shape of the uterus is going to cause problems with implantation of that fertilized egg. These can often be asymptomatic. A lot of times they're not detected until there's some symptom that gets an X-ray or a CT or an MRI of the uterus done. They're treated with either hormonal therapy or surgery if necessary. A lot of times a watch and see approach is kind of taken, where the other problems are treated, but the myomas are left alone and the fibroids are left alone. So here's what those look like. Let's see, this is the uterus here, and that would be a fibroid here. So they can get quite large. These aren't the greatest pictures because I don't really show you what. But they grow in the wall here. So you can have a fibroid here or here. If there's a fibroid that kind of grows out into the uterine cavity, that would be called a polyp. So these are, that would be an endometrial polyp. Other types of benign tumors, ovarian cysts. There's a variety of these that occur. They usually last about 8 to 12 weeks. Now, they often cause symptoms during that time, but a lot of times a wait-and-see approach is taken again because they'll disappear without complications. A cyst is just a fluid-filled space. So you can imagine that once this cyst ruptures, for whatever reason, it'll go away because that fluid won't be contained anymore. It'll spill out into the peritoneal cavity, and then whatever was left will be healed. So they're usually multiple small fluid-filled sacs. And then if they rupture or cause other problems that cause bleeding, bleeding is a problem. Bleeding causes inflammation of the peritoneum. It causes inflammation of the female reproductive tract. So if an ovarian cyst is bleeding, then it needs surgical intervention to be taken care of. Otherwise, we're just going to watch and see if it goes away. So we do this, we diagnose these by ultrasound or laparoscopy. Usually today it's ultrasound. You look at the ovary and it has this big fluid-filled black void in it, which is full of water. Polycystic ovarian disease, PCOD, people call this. This is where a fibrous capsule surrounds the follicles of the ovary, so they can't rupture. So this thick capsule keeps them from rupturing. Whoops. And here again, it can be hereditary. And what it causes is an absence of ovulation. If an ovarian follicle, if you remember your anatomy, follicle-stimulating hormone gets one of the primary oocytes to start developing, and it forms an ovarian follicle, then that ovarian follicle ruptures, the egg comes out and goes into the uterine tube. Well, if there's fibrous capsule is present, that rupture can occur. So ovulation doesn't occur and infertility ensues. And it also causes hormonal imbalance because that ovarian follicle secretes estrogen. And if it doesn't rupture, it can't become a corpus luteum. So we have an imbalance between estrogen and progesterone, as well as LH and FSH. So it throws the whole feedback loop out of whack. So we get amenorrhea because of no ovulation, no menses, because if there's no ovulation, there's no corpus luteum to grow up and then disappear. Hirsutism, this is from the high levels of androgen that this brings about. So this is growing more male pattern of hair distribution. The treatment can be surgical wedge resection, where they'll take a wedge out of this fibrous capsule or some pharmacology dealing with hormones. So these cysts this is an ovarian cyst, not a PCOD cyst, but an ovarian cyst can get huge, as you can see. So this is one where they obviously took the ovary and the cyst. This would be rare, but if it got to be that big, people would do something about it. Normally they look like this. See how there's a cyst right there? Do you see that from where you are? So that's normally what they see on ultrasound, is this little 1 centimeter or less cyst. But this is an extreme example of an ovarian cyst.
The biggest ovarian cyst.
And then on to the breast disorders. So fibrocystic change is what we typically call this, but fibrocystic breast disease. So this is a wide range of breast changes. And basically this came about as we started x-raying the breast. So with mammography, every once in a while we started seeing an increased density of breast tissue on the mammogram. So we learned about it, and it's a cyclical occurrence of nodules or masses in breast tissue. So there is an increased risk of breast cancer, but only if atypical cells are there. So when this fibrocystic change is seen, very often a biopsy will be done, and women, of course, get very worried during that time. But more often than not, this fibrocystic change doesn't actually contain any atypical cells. So it's of no concern for breast cancer, although we'll continue to follow it to make sure that nothing changes. The increased density of that area makes self-examination difficult, which means that scheduled mammograms are going to be required. And then there's we see increased cystic masses with caffeine intake as well. And then the true tumors, the true malignant cancers, carcinoma of the breast, increased incidence after age 20. Usually women are between ages 50 and 69 with carcinoma of the breast. Usually the tumors are unilateral. And the earlier the onset, in other words, the younger you are, the more aggressive the tumor usually is. And that's for carcinoma, because there are other types. Usually it arises from the ductal cells. So if you remember your breast anatomy, there's the ductal system, and then there's the alveolar system that actually produces the milk. So the carcinomas usually arise from the ductal system, because that's connective tissue. They metastasize, usually through the lymph nodes, but early in the course of disease. So this matters. If we find a carcinoma, we're going to want to get the lymph nodes very quickly, because this disease tends to spread to lymph nodes very early. And then if the tumor has estrogen or progesterone receptors, we can use those receptors to affect the tumor. So if it has estrogen receptors and estrogen promotes its growth, then we can squash estrogen out of the patient and slow down the growth. Same thing with progesterone. So predisposing factors, a first-degree relative with the disease, that's your immediate family. So a mother or a daughter with carcinoma increases your risk. There's a strong genetic predisposition for carcinoma. High exposure to estrogen increases the risk for breast cancer. This is one of the reasons why in birth control pills they try to keep the estrogen level as low as will be functional, and that's to reduce this high exposure to estrogen. Nulliparous, that's not having had any babies or a very late first pregnancy, also increases the risk of breast cancer. So, and we're seeing this more and more as women delay pregnancy for longer and longer. We're seeing an increased risk of carcinoma because of that. And then the usual cancer things. Lack of exercise, smoking, high-fat diet, radiation therapy to the chest for some other reason. This is a common one. Anytime you have radiation for any reason, you increase the risk of cancer. Even though the radiation is meant to kill cancer, and it does, but it also destabilizes other cells that are in the way of that radiation. So sometimes radiation can beget cancer as opposed to just end it. And then if there's cancers of the uterus, the ovaries, or the pancreas, that also increases the risk of carcinoma of the breast. So change on a mammogram is often the presenting sign. A single, small, hard, painless nodule This is one of the reasons why we encourage women to do self-examination, is to find these things early. And then later, actual distortion of the breast tissue where it becomes obvious even by sight, dimpled skin, a discharge from the nipple. We confirm it with a needle biopsy. So we take just a little tiny piece and we look at it under the microscope or ultrasound. The course, metastases usually occurs by the time these tumors are only 2 centimeters in diameter, so fairly small. So metastases occurs early, and it usually goes through the axillary lymph nodes. If it makes it through the lymph node sentinels, then you're going to see it in these 4 places: bone, lung, brain, and liver. And if that list looks familiar, it's because it's a very common list for metastases. All 4 of these things receive a great deal of the blood supply every minute. So if a tumor is in the blood, the most likely places it's going to land are the bone, lung, brain, liver. So this is just the course of metastatic breast cancer. The primary tumor breaks off little pieces, and it either goes into a lymphatic vessel or a vein. If it goes into a lymphatic vessel, this is the most common. It'll end up in a lymph node. It'll start growing there too. Once it gets into the venous system, then it has to find a place to take up residency. So it gets into a capillary bed, attaches, and then starts invading, and then soon we have a secondary tumor. As this process repeats, we end up with multiple tumors. Okay. So treatment, it can be either lumpectomy or mastectomy, depending on the size of the tumor and the concerns for aggressive spread and metastases. Lymph nodes are often removed as well, but it depends on the stage of the disease. If it's a very small tumor without much concern about aggressiveness under the microscope, then they may not take lymph nodes. They do a tissue biopsy to see if there are growth factors present in the tumor that can be used to modulate the disease. In other words, kill the tumor. This is where they're going to look for those estrogen receptors and progesterone receptors. And then radiation can be done either before or after or both. So this is showing you that here's the tumor right here, is here in the middle. You know, breast tissue has kind of this fatty look, but really this whole thing is kind of tumorous in appearance, but the middle is most concerning here. All these cancers have staging systems, which are too complicated to memorize, in my opinion, because you can always look them up. But basically, staging tells us about prognosis, and it guides our treatment. If there are those specific receptors, then we're going to target those if we can. So carcinoma of the cervix, cervical cancer. Most of these are due to HPV, which is human papillomavirus. The very same virus that causes warts has many different types, so it's a big family, so to speak. But several of these types have been shown to cause cancer of the cervix. So it's a sexually transmitted virus. There is now a vaccine for HPV, and a lot of women are getting it because it can greatly reduce the incidence of cervical cancer. The routine pap smears are the way we try to catch this early before it becomes a problem, before it takes hold. So we take some cervical cells and we look at them under the microscope, and we try to identify the early treatable stages before it's invasive cancer. So pap smears should begin by age 20 or in the year that sexual intercourse begins. And then at intervals by the healthcare worker. Usually it's once every year, once every 2 years, depending on your STD risk. So here's a positive pap smear. These are normal epithelial cells here, and the ones in pink are abnormal. You see how those are kind of funny looking? They're not nice and round cells. And they're also stained to be a different color because they're not normal. The course of the disease, it starts with dysplasia. Dysplasia is just a small amount of abnormality in the cells. They're not quite in the right shape. They're not quite growing in the right way, but they're not obviously trying to invade your neighbors yet. So that's dysplasia. And then if dysplasia goes on, we get an in situ tumor. In situ just means in place. So this is not metastatic or invasive. It's just present. And we find that on the mucosal surface. If this is left alone, it will invade and get into the submucosa of the cervix. and then from there it'll invade and spread to adjacent organs, so it'll start getting bigger and bigger in place, and then eventually it will metastasize. Now, cervical cancer is usually late to metastasize, so it's not like breast cancer that's kind of early to metastasize. So we talk about this because this is what you get back on the Pap smear. You know, is it normal? In other words, are the squamous epithelial cells normal for that region? Dysplasia means that there's a little something wrong with them, but not anything we need to do anything about right away. So we'll watch that sometimes. If it's severe in this range, we're going to remove those cells either by a procedure called a LEAP or other ways. You can freeze them too. After that, we're starting to look at real cancers. So malignant neoplasm, carcinoma in situ, and then eventually invasive carcinoma. So these top three are what we're trying to use the Pap smear routine to catch.
So they can be severe before it's like super big deal. They can still like scrape them out.
The dysplasia can be severe because it's still dysplasia. They're not. It's not a neoplasm yet. In other words, it's not dividing out of control. It's just not dividing right. But what we've found is that dysplasia becomes neoplasm. So yeah, this is where we usually do something about it to destroy those abnormal cells.
So when you have a leak done, then has it taken care of it, or you're just drastically slowing that cell growth?
No, if you wipe out all the dysplastic cells, you've eliminated your risk from that cell line anyway.
Okay.
Because those cells are gone. Because usually they are visible in a certain area. You know, you can see where the area is, and then you take any concerning areas out, and they'll grow back.
Can you have a normal Pap, but then that still actually have HPV because it's not showing at that time?
Yeah, you can, because remember, a Pap smear takes just a sample. You know, it doesn't get all of the area that of concern, but it's pretty indicative that you're healthy. Yeah, normal is a good thing. It's not. It's the false negative rate. In other words, your test came back negative, but you have disease, is very low with the Pap smear, because that's exactly what they're trying to do, is have a low false negative rate to catch every single one. It's why there are so many repeat Pap smears done, because the first one, we look anything that's slightest bit abnormal, we'll bring you back in and do another one. So the risk of missing one is very low. This is just what the carcinoma of the cervix looks like. You know, this would be normal appearing out here, and then this mess in the middle is that carcinoma. Cancers are always ugly. Risk factors, age less than 40. So this, unlike some of the other cancers we've talked about, this isn't a cancer of the old, this is a cancer of the young. HPV, viral infection, multiple sexual partners, early sexual intercourse, smoking, and then a history of prior STDs all increase the risk of cervical cancer. And then the uterus also gets cancer. So most commonly, carcinoma, cancer of the uterus, is in postmenopausal women. The first indicator is usually painless vaginal bleeding, which you can imagine would get a postmenopausal woman's attention because she has not had periods and then suddenly she starts bleeding again. So it creates a way to identify this reasonably early. So age greater than 50. High-dose estrogen hormone replacement treatment is a risk factor here. You know, this estrogen hormone replacement therapy for postmenopausal women is a balancing act in some ways, because you have to balance the risks with the benefits. And one of the risks is increased risk of cancer of the uterus. Now, this is for high-dose hormone treatment without progesterone. So what they do today is they have a lower dose estrogen than they did at first, and they include some progesterone as well to help balance the endometrial growth. Obesity increases the risk, as does diabetes. So Pap smear doesn't detect cancer of the uterus. It's only cancer of the cervix that detects. So usually cancer of the uterus comes from the glandular epithelium, so this is the endometrial tissue, so in some ways this is an endometrial cancer. It's relatively slow growing, but it will invade. So even though it doesn't grow real fast, it breaks down tissue barriers. So it grows into the myometrium, it grows into other tissues. And then the staging is based on how localized it is. Is it just in one place in the uterus, or is it all over the uterus? And we use surgery and radiation. Oftentimes in postmenopausal women, a hysterectomy is used because the woman is not interested in having more children. Today, a hysterectomy is not major surgery. It's outpatient oftentimes because they can do it laparoscopically or through the vaginal route. So that's commonly used, and then radiation.
So if you were to have uterine cancer, but you are still, you're not postmenopausal, what would be another indicative sign? Because obviously you're.
That would be tricky. Maybe that's why we don't see it very often, is because we don't know it's there. But it would be abnormal bleeding, is what the sign would be. So you, instead of bleeding with your cycle, you bleed all the time. But I can't give you a good answer to that one. I don't know.
Okay.
So here's what that looks like. The uterus has been taken out and open. Here's the cervix down here. You can barely see the shape of the thing because its carcinoma is taken over. And then ovarian cancer. This is a bad actor, ovarian cancer is. There's no reliable screening available. So oftentimes it's a bad actor because we don't even know it's there until it's just absolutely terrible and everywhere. But if we're concerned about it, transvaginal ultrasound, oftentimes it's not detected until a pelvic exam where a large mass is detected in the ovary. So you can imagine if it's big enough to be detected in a pelvic exam, it's pretty good size because the ovary normally, is only about that big. So it's going to have been there a while. That's why we call it a silent tumor. So we're looking, research is looking for markers, like there is for prostate cancer, like the PSA. We're looking for something similar for ovarian cancer so we can catch it early. There's different kinds, vary in aggressiveness. Risk factors, obesity again, early menarche. Also, just like with breast cancer, nulliparous late first pregnancy. It's kind of like, there's something in nature that if you don't use the reproductive system for what it's intended for, which is to make babies, that it's like stuff comes back to get you. So breast cancer and ovarian cancer, higher risk. The BRCA, this is a breast cancer gene, but it also indicates an increased risk for ovarian cancer. And then use of fertility drugs. Some of these fertility drugs really stimulate the ovary in a giant way. And anytime you do that kind of thing, you're going to have an increased risk of tipping some cells outside of normal control, and then you've got a cancer develop. Oral contraceptives that have progesterone in them are somewhat protective for ovarian cancer. And then usually the treatment, remember, these are usually advanced by the time you're diagnosed. So you're going to have surgery, oftentimes in multiple areas, and then chemotherapy. And then finally, infertility. I think this is our last topic.
She did well.
Anyway.
She didn't pronounce that one.
Can be either male or female or both. So both parties have to be considered an infertility workup. And today, oftentimes they are. An infertility doctor will want to see both parties involved to do a workup for both the male side of things and the female side of things. It can be hormonal imbalance, age of the parents is a big one, increasing today as people delay childbearing. The age of the parents comes into play in fertility. Structural abnormalities, many we've talked about already. Infections like PID, we talked about those. Chemotherapy hits the gonads pretty hard, so that can cause infertility. If there's no gametes, there's no possibility for pregnancy. Workplace toxins like lead can cause infertility as well as some other things, and other environmental factors, and then sometimes idiopathic. All right, so the STDs. Chlamydia, most common. Chlamydia is the most common STD. It's caused by C. trachomatis. And in the male, it causes urethritis and epididymitis. So we get symptoms from those two things. So dysuria, itching of the urethra. The classic symptom is a white discharge from the penis, which is pus. And that's urethritis. If it's an epididymitis picture, you have a painful, swollen scrotum. Usually it's unilateral. Then you get fever. And oftentimes the inguinal lymph nodes will be swollen. So classic picture of chlamydia is the white discharge and then swollen inguinal nodes. In females, it's often asymptomatic. So that's a problem because we've got an ongoing infection, but it doesn't give any symptoms. So PID is often the first presenting symptom of a chlamydia infection. So by the time you know you have it, you're already in a potential infertility causing disease. So it's one of the reasons why we routinely check for chlamydia in women is because, and in men too, but in women in particular, because there's no symptoms, asymptomatic infection. Newborns can be infected through the birth canal. So another reason why we check for chlamydia for almost all women before delivery to make sure that's not there. Gonorrhea is caused by Neisseria gonorrhea, so it's the same family as Neisseria meningitis. It's growing resistant, so resistant to penicillin and tetracycline, but there's still lots of good medicines we can use to whack gonorrhea. In the male, the most common inflammation, again, urethra, site of inflammation. While some males are asymptomatic, gonorrhea is one of those bugs that lives inside of cells. So men can be, in chlamydia, women are often the asymptomatic carrier, asymptomatic spreader. In gonorrhea, men are often the asymptomatic carrier. Again, females also frequently asymptomatic, and then PID and infertility again. So same picture. Gonorrhea can infect the eyes of the newborn. We talked about this, I think, when we talked about the eye disorder, so it can cause irreversible corneal damage. And then it can spread to the rest of the body. Gonorrhea can spread to the rest of the body. So this is acute epididymitis. This is normal testes here. And then this giant, large thing is the epididymis that's all full of pus. Isn't that a lovely picture? Syphilis is not to be forgotten about. You know, syphilis has been around for a very long time, but it's still present today, and it's just as bad as it ever was in terms of what it does to you. So we have to always keep our eyes out for syphilis, even though it's relatively rare in our population. It's caused by a spirochete, the Treponema pallidum, which you probably learned about in micro. Did you learn about that one in micro? Yep, okay. But it's a little weird because it has several stages, syphilis does. The primary stage, which is when we would like to detect it, presents with what we call a chancre. And a chancre is kind of a weird lesion because it's a painless, firm, ulcerated nodule. So it looks like it should hurt a lot, but it doesn't hurt at all. Because an ulcer always looks like it would hurt. You know, that's like a crater in the skin where the skin is gone. But in syphilis, that chancre doesn't hurt, and that's at the site of infection. So any of those three regions. And it occurs about 3 weeks after exposure. It heals spontaneously, so the chancre goes away. The first sign of syphilis dries up and goes away, but the patient stays contagious, and they still have the disease. So this is one of the reasons why why syphilis goes on like it does. So this is a chancre. This, see right here, that's an ulceration on the head of the penis right there. And that doesn't hurt. So even though that looks like it would hurt, it doesn't hurt. So it's kind of, that's the thing to remember about syphilis is the chancre. If that's untreated, then we go on to the secondary stage, which is a systemic infection. So we get a flu-like illness, the usual symptoms of systemic infection, fever, malaise, muscle aches, anorexia, those things. Again, self-limited, so it goes away, but the infection stays. That's syphilis's method, is the symptoms it causes go away, but it stays around until you get to the tertiary stage. The latent stage, which occurs after the secondary stage, can go on for years. So now you have a patient who's asymptomatic, infected with syphilis, and very likely still having sex and transmitting it to others. So you have a perfect typhoid Mary kind of thing. So they're spreading it. And then tertiary syphilis is where you really start to get irreversible changes. So you get gummas, which are little kind of like tumors in the organs and major blood vessels, and you start getting CNS effects. So this is neurologic syphilis or neurosyphilis. So you get dementia, blindness, motor disabilities. People think that the dementia of syphilis is what drove King George mad. Madness of King George. Syphilis can be transmitted to the fetus during gestation, so in utero, that's because it can travel around the bloodstream. And the baby is born with tertiary syphilis, so the changes are not reversible. It doesn't go away. So we try to treat this, or we treat this with antimicrobial drugs And we look for it often, treat it when we find it because it can be present without symptoms. And then in terms of the viral infections, genital herpes, this is HSV2 and HSV1. And we get similar lesions to what we talked about in the skin chapter last week, which is blister-like vesicles that break open to form an ulcer. So the outbreaks of herpes are usually preceded by tingling or itching, just like they are with a cold sore, but in a different region. That's kind of genital herpes thing. It's just like a cold sore, but in a different spot. And then the lesions are extremely painful. You know, the genital areas have a very rich nerve supply, so you can imagine that exposed skin there, like a cold sore, is going to hurt quite a bit. After the acute stage of this blister-like vesicle, the virus migrates back to that dorsal root ganglion, so it hides in a nerve cell and it can stay there your whole life. So the infectivity or the contagiousness goes up when symptoms are present. So one of the common methods today of treating people with herpes is whenever they start to feel this tingling or itching, they start medication so that they're not as likely to spread it to their partner. So here's a herpes lesion here, and here you've got a couple, 1, 2, 3, 4, 5. This is the labia majora and minora, just to orient you. So yeah, these things hurt. The reactivation is very similar to what we talked about with the cold sore. So stress, illness, menstruation can bring this on as the immune system takes a little dip. We treat with antiviral drugs to reduce the transmission as well as to reduce the incidence of recurrence. But infection is lifelong because you don't ever lose those nerves. Genital warts, also called condylomata acuminata, also caused by HPV. So hopefully you know now that HPV causes warts and cervical cancer, because that's the two things it does. Warts in various parts of the body. Incubation here can be for a long time, so you can have no symptoms for 6 months or more before you start to develop the warts that vary in appearance. And wherever contact with the virus has occurred, that's where you're going to see the warts. And it, like we talked about, can predispose to cervical cancer. Lots of different methods to remove these. You know, there's freezing them, there's incising them, there's treating them with various kinds of medications. Trichomoniasis is a vaginitis caused by a protozoan. So this is an unusual one because usually, you know, we talked about yeast, we talked about bacteria as common microorganisms. This is a protozoan, so this is an actual little tiny animal that has a flagella and it can swim around, and it's a very, very busy thing to look at under the microscope. But trichomonas is a localized infection. Men are usually the asymptomatic carrier here because it doesn't cause symptoms in the men. Women, it can be subclinical, but it'll flare up. And for the same reasons that yeast infection will flare up, trichomonas will flare up because this protozoan is in competition with the bacteria that are normally in the vagina. So when that balance shifts, the trichomonas bloom. So you get intense itching, and you have to treat both partners or they'll keep giving it back and forth to one another. All right, that's it. So let us take, well, let's do questions. I always forget about the questions. All right. First up, which of the following causes that? Inflammation of the vagina with copious yellow discharge. We didn't specifically talk about this, but it's in your book. So. Have you not read this chapter yet?
Oh, I mean, I did. I forgot my clicker. Can I write it down?
Yeah. No.
Can't ever forget. Because I never forget. Joke, man. I actually forgot it last week when we were in it. Because that was the better one.
that's everybody. Alright, so copious, yellow discharge, foul odor, that's trichomoniasis. So candidiasis is usually white discharge, curd-like discharge with no odor. Trichomonas, experienced gynecologist can diagnose it by smell.
Oh,
Seriously,
If you do a rotation of one world, you'll know that
Yeah.
smell right away.
Which statement does not apply to vaginal candidiasis? It's like, what's the other one?
what's like the worst smell you've ever smelled? Is there one smell that makes you like dislike?
Abscesses can be pretty bad.
Those can get really nasty. I
Gangrene.
don't think it's gonna be the 1 years.
I don't think I do feel.
But STD stink is bad. It's bad.
I'm sorry, it was STD sting.
Yes. Because they all have their different smell. The one time in medical school that I passed out was rupturing membranes in a young girl who was very infected and pregnant at the same time.
Oh my gosh.
Oh, just a little way too much. All right, so what's vaginal candidiasis? Not an STD, so it can flare up. It is more common in women that are sexually active, but it's not an STD. It comes from ubiquitous flora. All right, why does severe pain occur with each endometrial or with each menstrual cycle of endometriosis?
What? What?
Oh, that's everybody. All right, so it's with each ovarian cycle, endometrial tissue all over the body is going to respond in the same way. So just like endometrial tissue in the uterus starts to fall apart when the corpus luteum degenerates, it does everywhere else too. So when it starts to fall apart, inflammation ensues because there's nowhere for it to go.
How is one not part of it? I thought you said it was the fibrous tissue too.
No, the fibrous tissue results from the scarring, but
Oh.
fibrous tissue doesn't respond to the hormone changes. That's when it hurts all the time. Which of the following may result from cryptorchidism?
What? You can't come to that.
Cryptorchidism.
No, you shouldn't. I answered your questions right last week, and now I'm stuck. That is not mine.
She's draining your intelligence by sitting next to you, is that it?
Yeah. It's very distracting.
So it's both of those. So cryptorchidism increases the risk for testicular cancer, and it causes the seminiferous tubules to break down. The scrotum the testes needs to be in the scrotum so it can be at that lower temperature. Without that, the seminiferous tubules break down, and then spermatogenesis ends. All right, a chancre is best described as what?
Oh, yeah.
Also called a canker. You hear it with a hard C too.
A canker, like a canker sore. How do you spell
It
that?
may, I don't know how you spell that. It may be the same word, but a canker sore hurts.
Yeah, bad.
Huh. Oh,
He didn't
oops.
say that, you said that.
That was deduction.
You're reading too much into the question. What is that? But not even that.
All right, make sure your number's lit.
Come on, number 15.
Remember, I don't have one.
I know, but we've had
But we've
17.
had 17. No, 17?
Somebody missed out.
I think there's
So that's, and we all got that because I said it. So it's a firm, painless, ulcerated lesion. All right. Well, take a little break. So let's take 10 minutes. And all we're going to do next is just review. So we'll go for a while here. All right. So
Which of the following dietary supplements has reduced the incidence of spina bifida?
Weird.
What?
I pressed D, it went DDA, or AA44D.
is it fixed now? Then go through.
Who's not using?
Those who are gone.
I know, but are you writing?
I'm writing.
Okay.
They'll pick it up when they get back. All right, so that's folic acid, otherwise called folate. Good, you all got that. Because I have a feeling if you're asked a question about spina bifida, like on a board exam or whatever, they probably will say something about folate in it because those two are linked, and we want everybody to know they are. All right, differences between type 1 and type 2 diabetes include... Long question to read.
It's nice and a long question, so you can read the first few words and know what's wrong.
All right, so it's only D. The rest of these are flipped. They're true if they're flipped. So type 2 diabetes can be controlled with adjusting diet. Type 1 requires insulin because the body doesn't make insulin anymore in type 1. In type 2, the body can make insulin, but it can't make enough to do what's needed. Type 1 diabetes causes weight loss. Type 2 doesn't really cause weight gain. It often results from weight gain. It results from obesity. And type 1 diabetes has more complications than type 2 because you're at an increased risk for diabetic ketoacidosis. And because typically type 1 diabetes starts in childhood, you have a long time with the disease. So you end up with the long-term complications. All right, in acute post-streptococcal glomerulonephritis, PSGN, that's called. The glomerular inflammation results from which of those?
Now, are these posted anywhere
I'm going to post them, probably not tonight, but tomorrow.
so that I have them to go back?
All right, so PSGN is not an infection. It results from a type 3 hypersensitivity reaction, so an autoimmune reaction to an infection somewhere else. So we call it post-streptococcal because it follows a strep infection. Usually it's a strep infection in the pharynx, so a strep throat. And what happens is some antibodies to that infection bind with an antigen, and they form these complexes that get deposited in the glomerulus, in the glomerular membrane. So they cause a breakdown of the glomerular membrane, so we get a glomerular nephritis. So a nephron and glomerulus infection. Ascending infection from the bladder, that's a ascending pyelonephritis. And the antecedent infection is that strep infection that starts it all, but that's not what causes it. All right, which of the following applies to oxytocin?
Here, I'll give you guys another few seconds. There you go, 12, 13, all right.
So oxytocin has two major roles. Those two major roles are to eject the fetus and eject milk. So they cause contraction of the uterus during delivery and after delivery, and ejection of breast milk during lactation. Actual formation of the milk is brought about by prolactin. So prolactin is what does that. And oxytocin is released from the pituitary.
Got it wrong, darn it.
All right, what is the typical joint involvement in RA?
Pounding this one into our head.
R-A. Oh, I remember this.
It's because arthritis is, you'll see it. It's a chronic illness that affects many, so you see lots of people.
You don't have that. I'll just put it. Sorry. Oh, you had 17.
That'd be right.
You believe?
Yeah, come on, I gave him the option.
Oh, we did? Told you. You told me no. No.
Yeah, if you're
I
not-
told you
if you're not
A.
into this kind of review, that's fine.
Yeah, get.
So the typical involvement here is bilateral small
Step on.
joints. This is one of the ways you know that it isn't an infection or something like that, because it's happening on both sides of the body in a symmetric way. So that's not going to be an infection. You know, an infection is going to be here or there, not at the same time on both. And it's the small joint. So typically think hands. If the hands are involved, that's rheumatoid arthritis. And you get those swollen knuckles and all that. A random single joint, that's often infection. And progressive degeneration in certain joints is usually osteoarthritis.
Okay.
Typical signs of a TIA.
What's that again?
I told you that would be cheating.
Are you sure?
Because that's what this is called out there in the real world.
That's everything.
I think so.
All right, so a TIA is a transient ischemic attack. It's kind of like as angina is to an MI, a TIA is to a stroke. So it's like a pre-stroke in a way, but it doesn't cause any lasting damage. So you get transient muscle weakness in a hand or leg. You can also get transient anything. Transient changes in vision if it's affecting the occipital lobe. Transient changes in hearing if it's the temporal lobe. This first one, headache, photophobia, nucleorigidity, you see that in meningitis. You also see that in a subarachnoid hemorrhage, so a blown out aortic aneurysm. All right, in cases of Guillain-Barré syndrome, what does the pathophysiology include?
I can't even pronounce that.
Guillain-Barré?
Guillain-Barré?
Guillain-Barré. And the history is typically, doctors don't name diseases after themselves. They are named according to their discoverers. So it's not like Doctors Guillain and Barré decided they were going to call it that. Other people did.
I don't happen to see it.
Like Alzheimer's, Dr. Alzheimer's. He didn't decide.
Dr. Old Timer.
All right, so when you think Guillain-Barré, think think ascending paralysis. So as the peripheral nerves get inflamed and then demyelinate, they work less and less well. So when you get the upper and lower motor neurons involved, you have an ascending paralysis. So it starts at the feet, and then eventually it makes it so you can't breathe. Which of the following is caused by Graves' disease?
What? Oh no. No, I mean like there's that many.
Oh.
There's not usually that many.
Sometimes there's 4, sometimes there's 5. All right. So it's increased metabolic rate. So Graves' disease is an autoimmune disease where there's an antibody that behaves to the body like TSH. So it looks like TSH to the hormone or to the thyroid gland. So it causes increased levels of T3 and T4. It looks like epinephrine and norepinephrine because Graves' disease people have fast heart rates, they have a high metabolic rate, they sweat, they're hot. So it looks like epi and norepi, but it isn't. It's actually thyroid related. So you get an increased metabolic rate, it's why they lose weight, and they're warm, and they're go, they have difficulty sleeping. And let's see, bradycardia and hypothermia is just the opposite. That's caused by hypothyroid symptoms, and Graves is a kind of hyperthyroid. And the thyroid gland is usually normal size or increased in size as it tries to meet the demands of this invalid TSH, this fake TSH. All right, in which type of neuron is progressive degeneration occurring in ALS? All right, so it's, whoa, look at that. Okay, ALS. 7%. That's probably one person got it. Okay, amyotrophic lateral sclerosis. This is also called Lou Gehrig's disease, which some of you may have it filed like that. But it's amyotrophic. A myotrophic is a thing that makes a muscle move. So an amyotrophic means there's a lack of muscle movement. And we call it a lateral sclerosis because that's the part of the spinal cord that affects, is the lateral bundles, and it causes them to degenerate or sclerose. So we get, it's motor neurons. So these people have both spastic paralysis from lower motor neuron, and upper motor neuron effects are flaccid paralysis or weakness. Actually, I think I reversed those. But anyway, it's upper and lower motor neurons. And sensory neurons are usually spared. So they don't have a sensory deficit, they have a progressive paralysis. All right, which of the following is an example of conduction deafness?
What'd you get? You're probably wrong. No.
All right, so conduction deafness means you can't get sound waves from the outside into the organ of Corti. So it's a problem usually in the middle ear with the TM or with those bones in the middle ear. So anything that reduces the movement of the ossicles is going to cause a conduction deafness. It isn't that the organ of Corti, which is the hearing organ, it works just fine, but it can't get the sound waves. So one reason for adhesions in that middle ear cavity is chronic ear infection. So one of the reasons that we treat ear infections is to reduce the chance that we're going to upset those ossicles. The rest of these would be neurologic causes of hearing loss, neuroconductive. All right, an accurate assessment of the extent of permanent spinal cord injury can usually be completed when? All right, so this is the idea of spinal shock. So you can't assess the extent of damage right away because the spinal cord gets inflamed and it kind of shuts down and then it slowly recovers and heals. So after 10 days to 2 weeks, if there's no complications, then you can actually assess how much spinal cord damage there is because the swelling will have gone down and all that will remain is the lasting deficit. Because immediately after this one and this one, it's going to look much worse than it will be in the end. All right, which of the following describes the lesions of psoriasis?
Wait. Because there's no. Okay, fine.
So that's silvery plaques on the erythematous face. Oh, very good. Lots of you got that. You don't see very many silvery plaques. You don't see very many silvery things. So if you see silvery, that's going to be psoriasis. And in your clinical experience, if you have like a friend who's on the floor in a fellow, doing the clinical same day, and they've got somebody with a rash, go look at it. Because really the only way to learn the skin stuff is to see it for yourself. Once you see it, you'll never forget it. You'll remember psoriasis forever if you see somebody with it. What is the pathophysiologic change in Parkinson's disease? In med school and residency, if there was somebody with a rash, it was obligated. You had to go look at it. Because it's the only way to learn.
And that's why our hospital goes so much.
Why?
Somebody needs to come look at my rash. Who hasn't seen it before? I'm very encouraging.
We don't bill you for that. You'll
I kind
just,
of get mad about that because you do notice that.
what, the parade of medical students sometimes?
Not so much the medical students, but when I was in for 90 days for my kidney stones, we watched who came in and stuff. And it was like, why did he even see me? He wasn't even on rounds. It was just like, somebody needed to see me. I don't know.
It's because we have to learn. Just like you all learn in clinicals, you don't have to be there. You're not really, required, but it's the only way to learn about it is to see it.
But when
All
you're
right.
having a baby, it's very annoying.
Correct. I agree with you about that. You have to limit it in OB because it can be a parade otherwise, and women feel very exposed anyway. So, all right, Parkinson's disease.
Parkinson's disease is, think dopamine. There's two disorders to think dopamine about. Schizophrenia is too much dopamine, and Parkinson's is too little. And that too little comes because the basal nuclei, which normally secrete dopamine, start to degenerate, and that's what causes Parkinson's disease. All right. Which of the following conditions can cause immunosuppression?
You can move up, you know.
That's okay. Oh. I'm gonna make these slides like colored or something. Stars, flowers, waterfalls.
All right, immunosuppression. Good, lots of you got that. Cushing's disease, which is the presence of too much steroid over too long a time, for whatever the reason, whether it's steroid from the body's own adrenal cortex and medulla, or whether it's from the outside. But all that steroid around causes immunosuppression. So you all know that steroids reduce the immune system. Cushing's disease is too much steroids around. All right, which of the following is a sign of a detached retina from last week?
Pretty positive. I'm almost betting my life on it. No, that's a joke. Okay.
All right, so a detached retina,
Yeah.
an increasing dark area in the visual field. So obviously it's a thing people will notice. Instead of seeing a complete picture, there are these dark spots present. Painless blurring of vision, you'd see that with cataracts. Progressive loss of centralized vision, that'd be macular degeneration. And then eye pain, halo around lights, this would be glaucoma. Which of the following congenital defects is a common cause of cystitis in little kids?
No. How many are we doing? We're gonna get out of there. 51? You're cool.
All right. Good. Lots of you got that. VU reflex. Urine is supposed to only go one way, from the kidneys through the ureters to the bladder. VU reflex violates that order. So urine goes from the bladder back up the ureters towards the kidney. It causes the kids to not only have bladder infections, but be at increased risk for kidney infections, pyelonephritis. Which statement defines a sprain?
Brain. Oh. As opposed to a
Strain.
strain. I couldn't think of the word. No. Sprain.
So a sprain is a tear in a ligament. A strain is a tear in a tendon. So those two things get often confused. Rickets results from what?
I'm doing really badly. I told you
Means
yes,
you
over
have much study to do.
Much. Right after my statistics test on Thursday. I'm so jealous of you. I have a C. She's gotten a lot better though.
So rickets is a vitamin D problem. So vitamin D, phosphates, or calcium deficiency all can cause rickets. And what rickets is the bones actually get flexible. So, you know, instead of a nice hard bone that doesn't bend, they just bend, kind of like, you know, pipe that you can bend. So as you put pressure on it, they bow out. Phosphates are the other part of the mineral matrix of bone. Its bone is calcium and phosphate. And then vitamin D is needed to bring calcium in and to get it into the bone. Which of the following is characteristic of multiple sclerosis?
No, canker and chancre are not spelled the same.
Oh, like canker as in canker sore. I've always seen it C-A-N-K-E-R. Yeah. But I know I have heard the syphilis lesion called a canker or a chancre. Usually it's a chancre. All right. So multiple sclerosis is actually common in young people. It's another one of those illnesses that hits that 18 to 35 golden era when not many things go wrong with people. Multiple sclerosis is one in that list of things that can affect that age group. And it comes and goes. So it comes on and goes away, and then often it comes and goes in different ways. So you'll have a problem with one thing, then it'll go away, and then you'll have a problem with some completely different neurologic thing. What are the characteristic changes in the brain with Alzheimer's disease? All right, so when you think Alzheimer's disease, think neurofibrillary tangles,
I was thinking plaque.
also called plaques. So the plaques are made up of these neurofibrillary tangles. Basically, they're these little protein lumps or globs that are all over the brain. And then in addition, you get cortical atrophy. So on X-ray, their brains are too small and they lack ridges, so they lose the number of folds, so their brains get simpler and smaller. All right, the micturition reflex is initiated where? Or by what? A long time ago. We haven't had
just had it.
All right, so micturition is voiding. So what starts that whole voiding thing is increased pressure in the bladder. So the bladder distends, and at some point it begins to stretch. And once it stretches, then the process starts to identify that we have to urinate and then do something about it. So it starts with the bladder, and then it ends with relaxation of the external sphincter. So once that external sphincter is open, this results in this, and then if we voluntarily open the sphincter, then voiding occurs. All right, which type of microbe causes tinea infections? Yeah, this is one, you can't leave this class without knowing the
answer this.
And it won't be on the test because it's been on everything
Because you
else.
drilled
So-
And I know that one. I'll move on. It's probably true.
Because these are just basics.
We're all gonna chuckle when we see this on the test.
Because what you can't do is you can't,
Got it wrong.
you can't recommend antibiotics for tinea infection or it will make you look really dumb. So I want you to know that tinea is caused by a fungus. And frequently tinea infections require long treatment. Like tinea capitis, ringworm of the head, you can have medication for 6 weeks oftentimes because it's slow to die. All right, cystitis is more common in females due to why?
Because we get everything. Because we have any parts and then yes. We have moist, dark areas.
Oh, no.
That's funny.
Oh, no.
Some more than others.
All right, and it's because, oh, you all got that. Never mind. All right. What is the typical change in blood pressure associated with increased intracranial pressure?
Good. Me neither.
Yeah, this question you haven't seen.
Good. You're so black. That's what you are.
All right, so it's increasing pulse pressure. So what happens with intracranial high ICP is the heart has to push harder to get blood to the brain because the brain is under pressure. So the systolic blood pressure goes up. But because of that increased intracranial pressure, it's pushing on the venous system. So diastolic blood pressure goes down. So what you see is a growing pulse pressure, or difference between systolic and diastolic. All right, which of the following is a significant indicator of renal insufficiency?
Oh.
Okay, this is another basic knowledge question. You have to know this one.
Quit saying that, you're making me feel bad.
I'm not trying to make you feel bad, but
Well, it's happening.
this one.
Oh, yeah, and I know it from medication.
All right. So renal insufficiency just means the kidneys aren't working like they should. And whenever you see a high urea or a high creatinine, that's kidney failure or at least renal insufficiency until proven otherwise. The kidney's job is to get rid of metabolic wastes. And the primary metabolic waste is urea. So if the urea is high, it means the kidney isn't getting rid of it. It means the kidney is not doing its job. Creatinine is formed at a consistent rate and is eliminated by the healthy kidney at a consistent rate. So if creatinine is high or going up, it means the kidney isn't working as well. So those two blood tests are kidney function tests. We get them to see if the kidneys are working correctly. Compensation mechanisms occurring in early DKA include which of these?
So what's the final gonna be like in here?
It's going to be 100 questions,
Oh,
multiple choice, and they'll all be questions you've seen before, not including the question-based review.
So testing.
So it will be taken, all the questions will be from past exams, homework, or clicker questions.
Okay. And they're all on Black.
And they're all on Angel.
Blackboard.
Who are you?
You must have went somewhere else. on Blackboard.
Aren't we?
All right, so compensation mechanisms are things that actually help alleviate some of the metabolic symptoms. So Kussmaul respirations are great big breaths in and great big breaths out. And they actually help to reduce the pH effect. They help to keep the pH less acidic by blowing off all that CO2. So they cause a little respiratory alkalosis to match the metabolic acidosis of the DKA. These things occur because of DKA, but they're not compensations, they're actually complications. So seizures, ketonuria, and polydipsia.
I had it in my.
All right, which of the following does not apply to SIADH, inappropriate ADH syndrome? Usually it's called syndrome of inappropriate ADH secretion. Okay, so we've talked about two major hormones that play a role in salt and water balance. That's aldosterone and that's ADH, or antidiuretic hormone. So ADH is antidiuretic hormone. So in this syndrome, we have too much antidiuretic hormone around, which means that we are antidiuresing. In other words, we're not peeing. So we hold on to water. That causes hyponatremia. It's caused by an excessive ADH secretion. It's triggered by things like head injury is a common cause of SIADH. And so we hold on to water. That causes severe hyponatremia. Sodium is managed by the aldosterone system, that renin-angiotensin-aldosterone system. So it's not affected here. We're going to have normal sodium retention, but we're going to have lots of water retention. All right. Which of the following is often the first sign of ototoxicity from drugs or chemicals?
Yeah. Positive. Yes, but I'm busy. Gee. I was thinking of the name, but it's just my notes and forgetting everything.
This idea has major clinical implications for you all. So if you have a patient who's on gentamicin, for example, a medication that's known to be potentially ototoxic. Ototoxic is toxic to the ear. Oto is ear. And they complain of ringing in the ears. That's an emergency. That's something you got to call the doctor about right away because tinnitus is often the first sign. If you discontinue the drug at that point, you can save the ear. But there are a number of medications that have adverse effects on the actual organ of Corti, the hearing part of the whole hearing apparatus, and it's irreversible. So you want to deal with that right away. Why do secondary infections frequently develop when pruritus is present, pruritic lesions? What, lost?
What would be a secondary?
Yep, think it through. When you don't know right away. I do it all the time because I can't remember all the facts.
Again, I just choose not to.
All right, so pruritic, that's itchy. So if a lesion is itchy, what are you going to do? You're going to scratch at it. If you scratch at it, you're going to introduce normal skin flora into the lesion because you're going to pull off skin on top of that lesion, and then that flora is going to get down in there. So lots of you got that. All right, which fluid is constantly secreted and reabsorbed through structures in the eye?
Good question. What do you think, Sophie? Well, I know what D is, so. You're an idiot.
Are you sleepy?
I was before, not anymore. Yeah,
Usually when
I could go all night now.
people sleep, they just get
All right, so in the eye, we have the vitreous humor and the aqueous humor. The vitreous humor fills that posterior chamber, so between the lens and the back of the eye. And it's kind of the consistency of really tough jello. It's very clear, and it's there from birth, and it doesn't, doesn't cycle. The aqueous humor is in the anterior chamber of the eye, and it's formed at the ciliary body, and it's reabsorbed at that canal of Schlemm. So when we have an imbalance between secretion and reabsorption, we have what disease? Glaucoma, very good. So the
Where you
pressure
can
goes
smoke
up.
pot.
Yeah, as it's remembered my son.
Wait a minute. I have a bloodshot again. Dr. Peter.
Tears, you can't, they're not reabsorbed, they actually enter the nasal cavity or are just swallowed.
What? That is crap.
Which of the following statements regarding acute necrotizing fasciitis
Oh, we're
is
not,
true?
can this be the last one?
No.
Please, Dr.
I
King.
can stop whenever you want. This is all for you.
If we don't stop right now, there's a good chance that I'll develop a stutter. Please don't do this to me.
Elizabeth, go to your room. Go lay down.
I gotta go study first.
This tends to happen every Tuesday night, though. It's not just you. It's a little bit everybody. We all get a little slap happy by the end of class.
Oh, I didn't answer yet. Oh, yeah, I did. What did I say? I did
Answer
say
again
that.
if you're not sure.
Probably right. You can just go.
We're missing two.
One just.
Okay.
And I answered. Yes. Yeah.
Alright, so acute necrotizing fasciitis is like the worst skin infection you can possibly get because it's rapidly, spreads rapidly and causes toxic shock. So it's one of the few skin infections that can kill you. Alright, an epidural hematoma is located where?
Every
Epidural hematoma.
You'll get asked questions about this fact on the boards, I guarantee it. Epidural, subdural, and subarachnoid bleeding. Know the difference. Have you studied yet?
No. Not quite yet.
Have you seen her cookie crochet answers?
Huh? No.
Don't look at them.
I don't look at performance, I just like to see it.
Wow.
Alright, so the epidural that's above the dura, so that's the only thing that's above the dura is the skull. So it's between the the dural matter and the skull is where an epidural is. A subdural is below the dura but above the arachnoid hemorrhage, or the arachnoid matter. And then an arachnoid hemorrhage, subarachnoid is below that arachnoid layer, lying right on the surface of the brain. Which of the following applies to cerebral palsy?
So next week, after the test, do we get to go point, or do we?
My plan is to review for the final. So to do this kind of thing over everything.
Alright.
So if you think this is useful for you, come. If not, you don't have to come. I won't penalize you for the
Missing clicker questions, not for the review stuff, because I know that this might not work for some people.
Oh, it should work for me.
I like it because I think it's an eye-opener to, oh my gosh, I actually need to study.
Oh my gosh,
All right, so cerebral palsy, the key here, it's non-progressive because cerebral palsy results from some brain damage. It's not a disease that's going on and doing more damage. It's caused by something either during development in utero or shortly after delivery causes brain damage. And that damage isn't going to spread. So whatever was there at birth, that's the way it's going to be. So it's non-progressive.
All right, which lesion distinguishes tinea corporis?
And if you know its other name, it should be easy.
Can you just tell us its other name? Fine. But why?
I just don't get
You have to wait.
I'm dealing with myself.
All right, so
Tinea corporis' other name is what? Ringworm. So
Oh, well,
it
that would have helped.
makes a ring. And so it's a ring of little vesicles, and the center is clear.
Done.
All right, this will be our last one. Which of the following is correct about Duchenne's muscular dystrophy?
Only women.
What was that one? Oh, there's no trash can in here. Yeah, I know, I do. Even in my office, I empty my trash and recycle things I'm supposed to. Yep. I live in the building with him, so I know. He's always on the watch.
Who is?
Dr. Knight.
Ganache? That's what I call him.
He's the green team police.
Yes, you do.
I am gonna poke you in the forehead.
All right, so Duchenne's muscular dystrophy, it ends up presenting by age 2 or 3 years of age, and it's big muscles that are affected first. So the muscles that control posture and get you up to a stand. So, all right, everybody, that's it for tonight.
See you go, Girl Scouts.